is Marina Elsabaawy. I'm on PGY2 Internal Medicine residency at Community Medical Center, RWJ. I'm presenting a case today about a spontaneous sternocleidomastoid hematoma associated with low molecular weight heparin. I would like to thank Dr. Okoh, Dr. Chajkowski, Dr. Singh, and Dr. Poco for assisting in preparing that poster. And the authors has no financial relationship to disclose. So here we are presenting a case that presented with life-threatening condition, which is a hematoma in the neck. It is known that the anticoagulation in new onset atrial fibrillation are used to prevent any thromboembolic event. However, any use of anticoagulation in critically ill patients poses a huge risk of bleeding. The case we are presenting had a chest VAS score of 4 and has blood score of 2, who subsequently developed a massive intramuscular sternocleidomastoid hematoma. One of the known major complications is hemorrhage in the use of anticoagulation, with specifically the low molecular weight with 1 to 10%. And we have a handful of cases of spontaneous anterior abdominal wall hematoma being reported until date, with varying of duration of the enoxaparin use. The one we are presenting, it's a hematoma in the neck. So that's a case of an 85-year-old man with past medical history of hypertension and hyperlipidemia, diabetes, presented to the hospital with altered mental status and found to have a MRSA bacteremia. Patient started on the appropriate antibiotic, vancomycin IV. On hospital day 3, patient had developed a new onset atrial fibrillation in an acute illness setting. His echo showed EF of 40 to 45%. His chest VAS score and his blood scores were calculated at this point, and risk versus benefit was made, decision was made based on risk versus benefit. And he was starting on therapeutic enoxaparin. On hospital day 9, the patient suddenly, without any trauma, developed an expanding neck hematoma. He developed neck pain and dysphagia from the hematoma. His vital signs at the time, including his pulse ox, were stable with no concern for airway compromise. A CT of his neck revealed the hematoma, as we can see in the image, the coronal and the sagittal image right here. Patient was then transferred to the intensive care unit for close airway monitoring and possible intubation if required. After 24-hour, the hematoma was noted to not to be expanding anymore. Actually, it was decreasing in size. So luckily, the patient didn't have to be intubated, and we didn't have to do any surgical intervention on him as well. His hemoglobin remained stable, and the patient remained hemodynamically stable. After he completed his course of antibiotic, patient was discharged home safely on antibiotics, cardizem and amiodarone. His atrial fibrillation became persistent, so there was a plan to restart the anticoagulation in the near future with outpatient follow-up. So low molecular weight heparin have several advantages compared to unfractionated heparin, including longer biological half-life, increased bioavailability, and predictable pharmacokinetics, negating in the need for monitoring. Its clinical use is widespread, ranging from treating and non-ST segment elevation myocardial infarction to thromboprophylaxis in post-operative HIF arthroplasties. However, low molecular weight heparin, including enoxaparin, associated with major and minor bleeding risk, commonly reported in the abdominal wall and rectus sheath, attributed to the location of the site of the injection. Major bleeding events from enoxaparin use in the setting of atrial fibrillation are rare, reported 1.6%. The case that presented here in this article highlights a very rare bleeding complication seen in patients on therapeutic enoxaparin. The importance of recognizing this potential complication is in the rapidity of subsequent management in order to prevent life-threatening hemorrhage. Thank you so much for having me today. Do you have any questions for me?
We have one question.
Sure.
Let me.
I couldn't hear the question.
Okay, can you hear me now?
Yes, I do.
Perfect. Thank you for your presentation. Did you consider cardioversion in this setting at all, given the new onset nature?
So the cardiologist, taking consideration the age, cardioversion was not planned, but the patient was started on amiodarone for chemical cardioversion.
Okay, thank you.
No problem.
Do we have any more questions? Thank you so much for your presentation.
Thank you so much for having me.